Okay. Thank you, everyone, for joining. I'm going to start sharing my screen in a few seconds. I'm Mr. Ganguly. I'm Obs and Gynae consultant, and I'm the lead for fertility and minimal access surgery for benign gynecology at Broomfield Hospital. And my scope of practice is very much the same here at Springfield Hospital as well. Today, I'm just going to talk about endometriosis a bit, and I've kept it very, very simple. So I'm more than happy to take questions at the end. And I'm going to talk a bit about the pathophysiology, what the presentations are, what the treatment options available are. I'm going to leave fertility out of this, though my special interest remains endometriosis and fertility. But we'll talk about the basics today. Um, Now, endometriosis, very simply, is a condition where the cells of the lining of the womb are present outside. So, and every month when somebody has a menstrual cycle, the lining which has gets shed through the cervix or the neck of the womb and the vagina, the cells which are trapped outside in the pelvis actually keep bleeding, and that's the physiology. And that can affect women of any age. My youngest patient has been 17. Um, it is a long term condition and it has a significant impact on life, but there are treatment options available. The causes of endometriosis, there are different causes. A lot of women ask me that my mother's had it, my aunts have it, my sisters have had it. Is it genetic? There are different theories about it, but yes, women in the same family tend to have a potential of having it, running it in the families, certain ethnic groups more. There are different theories about it, about an autoimmune or immunological basis for it, and how the cells of the lining of the womb spread through the tubes or through the bloodstream and get deposited in different parts of the peritoneal cavity. And it is probably a combination of factors rather than just one off on its own. How do you diagnose it? Of course, it comes with symptoms first. I will be talking about symptoms quite a lot. When patients ask me, Mr. Ganguly, should I have an ultrasound? Should I have an MRI? Excuse me. Both ultrasound and MRI may suggest endometriosis. As a diagnostic tool, MRI is probably better. And when ultrasound is not telling us very well as to what a pelvic mass is when we are seeing, MRI is probably superior. I'll show you pictures of what rectosigmoid means and what that endometriosis is. And it is that area between your back passage and the womb, which is significant endometriosis. An MRI is definitely better than an ultrasound in picking up endometriosis in bladder and in those areas. As far as ultrasound features are concerned, you will be able to see big masses on ultrasound. Little bits of endometriosis, the MRI will not be able to pick up. And when we talk about these kind of little spots or blood splatters, it is essentially laparoscopy which gives us the best answer. The ultrasound is very good in picking up cysts, and that is what is known as endometriomas. And that is a very typical picture of an endometriotic cyst. And if I showed you, this is the entire cyst which you can see, and we call it as a ground glass appearance. And nearly the entire ovary has been replaced by this endometriotic cyst. But you can see where I have put my picture, where you can see normal ovarian tissue surrounding the endometriotic cyst. And these little areas down there is where the ovarian tissue is showing some activity of follicular activity or eggs being present. The gold standard remains a laparoscopy. That means we really have to put a camera inside for us to be able to see and do what is known as pelvic mapping and looking for endometriosis. The other bit, of course, is that we then take a bit of a biopsy from that area and you look under the microscope. The whole idea is that when you look under the microscope, the cells that you see should be representative of the cells that you see at the lining of the womb. And then you know for certain that this is endometriosis. But it may not always be seen under a microscope. We still have to go by the overall laparoscopy pictures. This is the normal anatomy. This is what we see on laparoscopy. That is the womb. You have the bladder there. These are the fallopian tubes and the ovaries. This is the bit that we are looking for, which is known as the pouch of Douglas. This is the lower bit of the bowel. The vagina is low down. And this is where you can get the rectosigmoid endometriosis that I was talking about. It can be anywhere. It can be in the bladder, it can be on the tubes, it can be on the ovaries, it can be on these ligaments, these white structures which are holding up the uterus, and it can be on the bowel, and all of this can be tethered together. And I will show you pictures of endometriosis that we see, but this is essentially a picture of the normal anatomy when we are putting in a camera and having a look inside. This is what we call is the early endometriosis. You can see with the uterus there, the fallopian tubes there, and the powder burn or the blood splatters that were talked about are all these areas which you can see. These are the red and these bluish areas. Yes, on laparoscopy, it may appear as early, but we should not be fooled by this because these endometriotic deposits, though whatever we are seeing, may well be further deep into the tissue rather than just what we are seeing. In these circumstances, where I'll talk about the treatment, the idea would be to cut those areas out completely, and then you get to the depth of that tissue which has been affected. This I have shown you, that's the womb, and you can see that from your previous picture that the fallopian tube, which is important from a fertility perspective, has now got stuck to the uterus, and you can't see the ovary very well from what you could see in your previous pictures, and this has now become a tubo-ovarian mass, and these are the adhesions, the flimsy structures, as we call it, and this is the endometriosis, and you can see that this has formed on the tube, and it is going to be a difficult discussion with the patient as to what do we do with this tube depending upon what the fertility options are. I showed you a picture of the ovarian cyst, and this you can see, and I have removed large cysts, 10, 12, 15 centimeters by laparoscopy. You can see that this is the uterus, this is the tube, that's the ovary on one side, which is normal, but you cannot see the ovary on the other side. And this large bluish structure with this black fluid which is coming out, which is altered blood which is coming out, is known as an ovarian endometrioma. So the whole idea, you don't remove the ovary, you open it up and you take the cyst wall out and try and retain as much normal ovarian tissue as possible. Now, this is kind of where, if you compare with the first picture that I showed you of the normal anatomy, there is no semblance of normal anatomy here at all. As you can see, the uterosacral ligaments here are no longer are obliterated, and the part of the bowel is now completely stuck. The ovaries are stuck, the tubes are stuck, and you can see here. So, this is the most severe form of endometriosis, and the disease is kind of more deep in the pelvis rather than what you can see. And in these patients specifically, where the bowel is involved, unless and until this part of the bowel is removed and then either stitched or repaired, the disease is never going to be taken away. And that is what deep infiltrating endometriosis affecting the rectosigmoid junction is known as. As I told you, as far as symptoms are concerned, patients will come with a myriad of symptoms, and it can be significant pelvic pain, it can be painful periods, it can be painful bowel movements, it can be painful sex, it can be difficulty in kind of falling pregnant. There are different ramifications. So, how do we treat this endometriosis? There is no absolute cure that we understand, but we are aiming at symptom control and we are trying to either relieve the pain, remove the tissue, improve the fertility, and reduce the chances significantly of the condition returning. Treatments for endometriosis, it is very unfortunate that in this country it takes women 5 to 7 years to get diagnosed with endometriosis, and patients are known to be going backwards and forwards, known to have painful periods, and they are drowned in painkillers. Ibuprofen, paracetamol, these are the common things. Other things like non hormonal stuff like mefenamic acid is given, and it's perfectly all right as the first port of call. Then we have got hormonal medication, contraceptions, we've got surgery, and there are different aspects of surgery. This might mean removal of just the bits of endometriosis, it might mean removal of the organs affected with endometriosis, removal of the bowel or the colon, or even the womb or the hysterectomy, which is a final solution, as we call it. A lot of patients will kind of go on with the hormone treatment, and that is fine. If you read nice guidelines surrounding this, it is perfectly reasonable to start hormone treatment. Most of these patients seem to be more sensitive to the estrogen hormone. So every month, when you have a cyclical period and there is secretion of estrogen, that estrogen makes and encourages the endometriosis tissue to grow and shed. So, very simply, limiting that estrogen can shrink the endometriosis tissue in the body and hopefully reduce the pain. The adhesions that I showed you in one of my pictures, where the tube and the ovary was stuck to the uterus, hormone treatment can do nothing about it and cannot improve fertility because you're suppressing the ovaries. But it is very effective in treating endometriosis, but they can have side effects. But of course, with the hormone treatment, pregnancy is then reduced, the chances, but this is essentially reversible, and contraceptive hormone and implants do not have any permanent effect as such. The commonest thing which the GPs give are the combined pill. We had estrogen and progesterone, of course. It releases the egg being released, makes the periods lighter and lesser. Most patients will be going on to it like in a what we say either back to back. They can take it cyclically, or they take three cycles in a row and then have a bleed. The whole idea is to minimize the amount of bleeding and improve the symptoms related to the bleeding. With the other hormonal treatment, there are different kind of progesterones that we have, which is essentially anti-estrogen, and they prevent the endometriosis from growing. But of course, progesterone has significant side effects. It has got bloating, mood changes. You can have weight gain. You can have irregular bleeding. There are different papers which suggest about using different forms of progesterone. A lot of places now use low dose norethisterone on a daily basis. The whole idea is to achieve amenorrhea or absence of periods. Marina, I'm sure a lot of you are aware of it, and that can stay inside the uterus for 5 years. Again, it works as a progesterone, so the amount of progesterone which is being secreted is very little. So you do not tend to have the side effects that the oral ones have. And of course, because it is locally releasing, it stays there for 5 years, offers contraception, and reduces the side effects, giving nearly the same symptom control. Of course, there are other injections. These are known as GnRH injections, and they're essentially to switch the ovaries off, and this causes temporary menopause. This is again reversible. It helps reduce the pain. A lot of us doing laparoscopic surgery for endometriosis give it before the surgery and at times after the surgery for a short period of time to achieve symptom control. So it is used in conjunction with the surgery to improve the efficacy and kind of bring down the inflammatory state of the endometriosis. And especially in my patients having IVF for endometriosis, this is something that it is recommended to be used, and we use it quite routinely for patients having IVF treatment. It is not used for contraception, but rarely are we using it for contraception. It is essentially a medical option that we are using for symptom control, either in conjunction with surgery or for something else like IVF. With surgery, there are different things that we can do. As I said, we remove or destroy the areas, and this surgery will depend on how much of endometriosis you have and what is the patient presenting with. The gold standard remains a laparoscopy. It is very rarely these days that we do a laparotomy for a patient with endometriosis, and as a matter of fact, a laparotomy should be avoided under nearly in all circumstances, because that is known to cause more adhesions and more problems, and that should be the first port of call. I've talked about hysterectomy, but that is the last resort in those patients where multiple surgical alternatives have been done and all other treatment options have failed, and that should be kept as the last resort. Laparoscopy, a lot of you are aware of it. We essentially do it as a day case procedure. Very rarely do we keep patients back in exceptional circumstances where you are doing significant amount of endometriosis surgery, especially where the bowel will be involved. In those patients, they stay overnight. But usually the earlier endometriosis surgeries, they are day case. It is done under general anesthesia, and we use very simple instruments, and they either apply heat and we usually cut them or excise them, and we try and take the adhesions out. And if there are cysts on the ovaries or endometriomas, we remove that endometriotic tissue, as we call it, or the cyst wall, and keep the ovary behind. The aim of surgery in young patients is always fertility preservative. We don't chop out ovaries and tubes unless and until there is a need for it. In this picture that I showed you, where the tube is affected, where there is an endometriotic nodule on the cyst, if the tube has got fluid collection in the tube, which is known as a hydrosalpinx. Hydro is water. In patients undergoing IVF treatment, of course, we either clip that tube or remove it. But if the tube is otherwise all right, we try and preserve the tube as much as possible. And of course, this is the whole idea, is to try and excise as much of the endometriotic tissue as possible. And we hardly do just diagnostic laparoscopies these days. It's essentially operative laparoscopy. That means you see it and you treat it at the same time. Depending upon the expertise of the surgeon, they will then do the amount of surgery they are comfortable doing. Otherwise, these patients with the significant endometriosis will be seen in endometriosis centers, of which there are quite a few scattered around in the east of England and other parts of the country. And as I said, the hormone treatment might be used after surgery as an adjunct, so that we get better symptom control with it and a better outcome. When we do this surgery as a patient, you should have a very detailed discussion with your surgeon, and the risk benefit analysis has to be done with your operating surgeon as to what are we getting into. A lot of my fertility patients, of course, we try and avoid significant surgery where it involves the bladder, bowel, ureter, and I at times work in conjunction with my colleagues at Addenbrooke's and Colchester, and we have a discussion and we have multidisciplinary meetings about what should be the best course of action for these patients with severe endometriosis where they wish to preserve the fertility. And most of the times, the surgery will be done to aid the fertility treatment rather than going and doing significant amount of surgery in the pelvis where we know that the blood supply will be severely affected, bringing down blood supply to the ovaries, reducing ovarian reserve. And this discussion as a patient you must have about what is it that we are trying to achieve from the surgery. What are the effect on future pregnancy? What is the impact on ovarian reserve? What is the impact on fertility should you land up with bowel surgery, with a colostomy? What are the alternatives to surgery? Is it medical suppression? What are the other fertility factors which are relevant in that? Is there a male factor? Is there a tubal factor? What other factors are involved? With the surgery, of course, with the hysterectomy, Sanjay is very good. We talk about hysterectomy as one of the options. Hysterectomy is the final kind of a solution. Now, don't expect that the hysterectomy on its own will cure you of your symptoms because if you have not treated the endometriosis in the pelvis, your symptoms of pain will remain. Most consultants will try and keep the ovaries behind because the ovaries are required because you need the estrogen, but that is always a tricky decision as to whether we will remove the ovaries and what are the implications of keeping the ovaries behind in these patients. But when you've got grade 4 endometriosis where the ovaries are stuck, you've got a rectosigmoid endometriosis, which is a nodule, and the ovaries are affected as well. In those circumstances, the ovaries will be removed. If the cervix cannot be reached, at times we just leave the cervix, which is the neck of the womb. You have to be aware that keeping the ovaries and the cervix, you can have endometriosis coming back. We've had patients where everything has been removed. Even then, patients have come back where endometriosis is on the vault of the vagina. It is rare, but it is well reported, and I have seen it in my clinical practice. When the ovaries are removed, all this discussion has to happen with you as the patient, with the surgeon. What happens post hysterectomy? What happens when you have symptoms of menopause? Do I need hormone replacement therapy? When do I need to start the hormone replacement therapy? Will I just be taking estrogen? There have been lots of papers about this now. Estrogen only HRT is now known that if patients have got that amount of significant endometriosis, that symptoms may recur. Now, the recommendation is these patients should be followed up for anything between 3 to 5 years. And usually, we now give a combined course of hormone replacement therapy with estrogen and preferably natural progesterone to minimize the risk of the recurrence of endometriosis in the pelvis. Because once the hysterectomy has been done, the entire anatomy of the pelvis changes. Going back and doing any further surgery on the bowel or in the pelvis becomes risky surgery. Thank you. That was all from me. I'm more than happy to take any questions from any of you.
Thank you, Mr. Ganguly. We have a question from somebody who's asked, is there anything that, dietary-wise that would affect people's sort of chances of getting endometriosis or any other fertility issues?
Not really. A lot of patients ask me whether they should be avoiding any plant-based estrogen food, but not really. But you see, It's quite an inflammatory state. So if the bowels are affected, a lot of patients find that some foods they become more intolerant to when they have it. And it's about looking at your diet and changing the diet according to that, whatever gives you symptom relief.
Mm. There's another question about whether endometriosis increases likelihood of having a miscarriage at all.
Okay. Now, I did not speak about adenomyosis, which is a bit different because I didn't want to complicate matters.
Mm.
There are different causes related to miscarriages. Endometriosis per se is not related as a cause for miscarriages. Okay, but so you should be investigated for other causes of miscarriages. But if there is endometriosis in the pelvis, then it should be treated when you're trying for a child. But on its own, it will not be responsible for recurrent miscarriages.
Okay, thank you. And then another question's a similar topic really, about having surgery for or having a laparoscopy. Would that affect sort of fertility wise of either increased chances of falling pregnant or adversely affect it?
Okay, it depends on the level of endometriosis that you have. Very early grade 1 endometriosis, 85% of patients will fall pregnant without any intervention. It is absolutely certain that if you've got endometriotic cysts on the ovaries, removing those cysts will definitely aid natural conception. It will definitely improve chances in IVF. If there is hydrosalpinx present where the tubes are affected, either clipping the tubes or removing the tubes will definitely improve chances in IVF. As far as rectosigmoid endometriosis is concerned, where the bowel is involved, most of my endometriosis experts who then liaise with me will prefer that the patient have either the IVF treatment or have a baby before they do extensive surgery, because when you start stripping out or cutting or excising endometriosis from the bladder, bowel, from the pelvic side walls, the entire blood supply, the nerve supply in the pelvis drops, and it is well reported that the ovarian reserve then drops. So the MRI should be well discussed with your consultant. The fertility options should be discussed before you do the surgery. But I gave you the situations and the indications where surgery, without a shred of doubt, will improve the chances. But the surgery should be done, it should always be keeping in mind that it has to be fertility preservative. We
Hmm.
do not want to do oophorectomies even for endometriosis. We prefer that you have ovarian cystectomies, retention of as much of ovarian tissue as possible so that eggs can be retrieved. If the ovaries are stuck at the back of the uterus and egg collection is difficult transvaginally, then I have separated the ovaries so that egg collection then becomes easy, so we are able to retrieve eggs. So there are different reasons why a laparoscopy will be required, but that depends on what your symptoms are, what the findings are, and what is it that we are trying to achieve in that surgery.
Okay. And the last question is about sort of fertility support for on the NHS for those who have got endometriosis.
Okay, I tell all my patients that if you've got endometriosis, depending if I've done a laparoscopy, depending my only last week I had somebody who's only 21 years old, and I've said that's fine. You've cut out all the endometriosis. I've left a marina. You should have a discussion with your GP, and if you've got significant endometriosis, please don't leave it for 3 years, 5 years to seek help. You should ask your GP to be referred to the fertility clinic sooner rather than later, because for in some patients it can be a progressive disease, can be status quo. Very rarely is it regressive and it stays as it is. So you should be referred to the fertility clinic as soon as possible so that surgical intervention, if required, can be done. if required, you need IVF. At the present moment, IVF funding is all over the place. But if you've got funding in your local area, then you should. And if we think that you can't, that natural conception cannot happen, and just because you have endometriosis doesn't mean you can't fall pregnant. I've got patients with endometriosis post surgery who've fallen pregnant. But when you've got the grade 3, grade 4, where your ovarian reserve has dropped drastically, then when you are 37, 38 years old, then waiting for a natural conception or trying other options is really not an option. Then you need to get on and move on with IVF. A 25-year-old girl with grade 1 endometriosis, I am not worried. She will fall pregnant naturally. A 37, 38-year-old who's got grade 4 endometriosis, tubes affected, multiple ovarian cysts removed, that person will need IVF. Then, if there is NHS funding, you be seen in the fertility clinic and get referred on. If there is no NHS funding, do not waste time. Move on to treatment, because once you're above the age of 40, anyway above the age of 37, the fertility potential will start coming down. The egg reserve will start coming down. The quality of the egg is going to come down. In endometriosis, when we take eggs, we have seen that they are gritty, they are granular, because the ovaries, it is highly unlikely when you've got that amount of endometriosis that the ovaries have escaped it. I've seen one patient last week. There was only the pelvis, but she's only 25 years old. The ovaries are fine. But 10 years down the line, I cannot predict what that pelvis is going to be. So look at how old you are. I say this to all my patients over and over again, that maternal age remains one of the single most important predictive factors. And of all the things that I worry about in my IVF patients, I only worry about endometriosis. I don't worry about PID. I don't worry about male factors of fertility. I don't worry about tubes. I don't worry about polycystic ovaries. It is the endometriosis that I worry about, the grade 3, grade 4 endometriosis in the elderly mother who's now 37, 38 years old, who's suddenly now decided that she wants to have a baby. Those are the patients that I worry about.
Okay, lovely. Thank you so much. I think that's it for questions now, unless anyone else wants to put a quick one in now, but I think that's most of them. So I'll probably say thank you very much to you, Mr. Ganguly, for that presentation. That was really good, very informative. And we're going to pass on to Mr. Kalka now, if you are ready to present.
Thank you. Thank you,
Thank you
everyone, for
very
joining.
much.
Thank you.
Okay,
Okay.
here is Mr.
Hi,
Kalka. Over to you.
hi, Julia. Thank you. Do you want me to share it, or do you want to share the
Um,
presentation, or
yeah, if you
what?
can share your screen, that would be good, and then you can go through at your own time.
Yeah, yeah. Okay, fine. Thank you. Let me just do that. Just get to look at sharing. Yeah, that's fine. Can you see it? Julia, can you see it?
Yeah, I think so. Let me just take you off the screen. That's better. There we go.
Yeah, okay. Thank you all. Thank you, Julia and the team, for inviting me. Thank you all for attending. And it was an excellent lecture by Mr. Ganguly, and I learned something from that. So thank you, Mr. Ganguly. So I'm going to talk about ovarian cancer, but um, so it's the fifth most common cancer in females, and women have a 2% lifetime risk of ovarian cancer. The one of the main things with ovarian cancer is that early detection is of key, and outcomes are generally poor if we are diagnosing that later. So that's one of the key messages, is that to diagnose early and then we have treatment options available. And that's what I'm highlighting, that early diagnosis is the key. But I would like also at the same time reassure you, the patients, that, if a patient, sometimes, we call something as a 2-week wait referral. That means that, the patients are referred by your GP as a 2-week wait to the hospital, NHS setting. So that doesn't mean that you have cancer. It is to rule out a cancer. Out of 100 women referred, only 7% may have a cancer. That's the bottom line we want you to sort of remember. Don't panic about these things, because 93% won't have a cancer. So it's not that, it's often it's cancer. Now, that's how do you diagnose, in the primary care means with your GPs. What are the symptoms we should be looking for? And thankfully, ovarian cancer is more of a disease of the older age, more than 50, but you can have the ovarian cancer earlier. Therefore, it's important to look for those symptoms. So when should you contact your GP? If you are on a persistent or a frequent basis, more than 12 months times a month, I know it's quite difficult, but this is by the definition of, the NICE guideline. But if you're feeling on a frequent basis, persistently abdominal distension, like having a bloating sensation, and you're feeling full and you don't have appetite, um, or you've got a continued pelvic or abdominal pain, and or else you could have increased urinary urgency or frequency. These could be one of the symptoms suggest you have ovarian cancer. So therefore you need to see your doctor, like, don't ignore these symptoms, see your GP, so that the investigations can be done. I'm just going to the next. Sorry, it's frozen a bit, so no, it's okay. Yeah. So what does the GP? So you have these symptoms. If you have those like persistent abdominal bloating, loss of appetite, persistent urinary symptoms, abdominal pain, then you contact your GP, or privately, whatever your situation is. So what the GPs would do is that they will examine your tummy to look for any ascites, which means any fluid in the tummy, or have you got any sort of swelling. If your tummy is feeling swollen, then that's something, which we need to take seriously. And if there is an unexplained, fatigue or changes in the bowel habit, so that could be other bowel causes going on, so which we need to investigate. So what we always say is that, okay, once you go to a doctor, we investigated that everything comes normal, but if your symptoms continue, then don't ignore it. You need to go back to the doctor to say the symptoms are persisting. All right. So how do we test it? How do we test for what will be the so if a woman more than 50 has symptoms of irritable bowel syndrome, like alternating constipation, anything we're not sure about, we are supposed to investigate that. This is because the reason why we say this is important is because this is one of the common presentation, because ovarian cancer is typically known to present to other specialties. They present to A&E with bowel symptoms because we think it's bowel related, whereas actually it's ovarian cancer. So that's why it's important that if somebody has got irritable bowel syndrome, which means with irritable bowel, you have an alternating constipation and diarrhea, or your bowels are upset, doesn't mean it's related to bowel. But when your doctor is you see the doctor, they should be investigating for ovarian cancer. Now, what are the tests? So first test we do is a blood test, something called a CA125. It is a protein which can raise in ovarian cancer. The normal levels are usually less than 35. But when your doctor does it, or when we do the blood test, if it's more than 35, we will arrange an ultrasound scan of tummy as well as your pelvis. But there are other reasons why CA125 could be raised. So if your CA125 is raised, doesn't mean that you have ovarian cancer. Don't get sort of worried about it, because as endometriosis can raise it, fibroids can raise it, or if you're a smoker, you've got lungs problems, it can be raised. So therefore, there's nothing to panic if your CA125 is raised, but we need to do further tests, abdomen. But if your abdominal ultrasound shows that it's an ovarian cancer or there's any concern, your GP would refer you on what is called as 2-week wait referral or target clinic appointment. That means hospital have got a duty to see you in 2 weeks' time. So supposing that is if it's abnormal, then your GP would refer, and I'll come to that in a minute. But if your results are normal, and if you do, your doctor does to see a one phase raised and doesn't scan, and the scan is normal, then actually then the doctor will say, look, it's all okay now at the moment, so go and see how things go. In few months time, if your symptoms are persisting, you need to see the doctor again to make sure that things haven't changed. So when you are referred to hospital, we'll do the CA125. And if you are a young patient, less than 40, we'll do some other blood tests, something what we call as alpha fetoprotein, beta HCG, which is a pregnancy hormone, LDH, as well as CA125, as there are different reasons for in a younger women who can have ovarian cancer or ovarian problems. Then we do something called as risk of malignance index. So it's just for your information. So we will look at the CA125 level, and we look at whether you're menopausal or not menopausal. And then the ultrasound will tell us some features which could be suggestive, more suggestive of cancer, and some would be a benign problem. So as I already told you, it's a cancer of more than 50 commonly. Therefore, if you're postmenopausal, you get a higher score, and if you're less than, still having your period, you get a score of 1. And if the ultrasound has got, solid areas and it's multiple cysts, and if it's 2 sides, you get a higher score. So you multiply these things, and if you got a risk of malignancy index of more than 250, there is a higher chance of ovarian cancer. If it's less than 250, we reassure you, and I mean, we'll talk about the options then. But if it's more than 250, then it may be more suggestive of a ovarian cancer, and then we will refer you to what we call as multidisciplinary meeting, where we sit with the radiologist, we sit with the oncologist, we just discuss these options, and then come to a conclusion as to what will be the best way forward for in your particular case. All right, so the most important thing is to have what we call as tissue diagnosis. We need to take some samples to diagnose if that was, if your RMI is more than 250, we need to get some samples to prove that it's ovarian cancer before we do any treatment. So this can now be done by, under CT scan. So under CT scan guided, we can do it. If it's not possible, we can do or put a telescope inside, which we have heard about previously with the endometriosis discussion, what's called as laparoscopic biopsy. If we can't get the sample, at least we need the fluid, which is one of the signs of the ovarian cancer, is the fluid around in the tummy, which we need to check for what we call as cytology. Now, as I've said, earlier stage, it's important that we diagnose earlier. So therefore, effective treatments are available. So we stage most cancers are stage 1, 2, 3, 4. Stage 1 is when it's just confined to one or both ovaries. And if it just extends to beyond the ovaries into your pelvis, that's called a stage 2. Then if the cancer further spreads to fatty curtain along with the ovaries, fatty curtain around the bowel, what's called omentum, or on the rest of your tummy, it's called stage 3, and it could spread to even small bowel or omentum. But if it extends beyond to your liver and to outside your tummy and to the lymph glands, it's stage 4. How do we treat it? In stage 1 to 3, we would usually discuss these cases and we'll discuss the options with you. But usually, first line of treatment would be a full hysterectomy. You would have a cut up and down the tummy, and we would THB, so means hysterectomy and removal of both tubes and ovaries. And we will also remove the fatty curtain around the bowel, what's called as omentectomy, and we'll sometimes remove some lymph glands. And then the idea is that to remove as much as possible, because we know that if we remove as much as disease as possible, it's always a good thing in terms of long-term survival and prognosis. So what, as I said, amount of disease left behind is an important prognostic factor. So therefore, these are operated by usually colleagues called gynae oncologists, who would do this routinely. So there are some centers of expertise. So that's what we need to be aware of. Now, once you have had the hysterectomy, once a patient has hysterectomy, then she would have a adjuvant, as in added on to chemotherapy. But you don't do it for stage 1, or if it's lower grade histology, but you would have 6 cycles of chemotherapy, what we call as carboplatin or paclitaxel. But you will be supported by the oncology clinical nurse specialist throughout this pathway. If it's advanced ovarian cancer, means stage 3 and 4, you do a biopsy, you diagnose that, and you do something called as neoadjuvant chemotherapy, i.e. you do the chemotherapy first, and then after 3 cycles of chemotherapy, you go in and remove the uterus and whatever the disease you can see. And then afterwards, 3 cycles of chemotherapy, do the surgery, and then you may have 3 further cycles of chemotherapy. So now, so this is just a brief overview of the treatment. But one of the things I'm just going to briefly talk about ovarian cyst, because this is what we commonly find. Young women find an ovarian cyst and they worry about having a cancer. Normally, most ovarian cysts are benign. So with any ovarian cyst, you can't do any medical treatment. You can't do anything about it apart from either you wait and see whether that will disappear by itself, or else you repeat the scan to check whether they've gone, or we can just say, look, it's been present for a little while, we don't do anything, or so we will probably have to sort of refer as well. Again, many of the factors when you're managing these would depend on your fertility status, whether you're pregnant, premenopausal or postmenopausal. Particularly if you're desiring fertility, as Mr. Ganguly has alluded to, we've got to be a bit careful in destroying any eggs. So we got to discuss the options with you, because anytime you do an operation, there's a risk that you may lose some eggs. So we got to be a bit careful with these ovarian cysts. So what are the features which we say benign, i.e. likely to be nothing to worry? So if it's one cyst, and if it's less than 10 centimeter, there isn't any what we thickened areas, what we call a solid component. If it's got a smooth outline, and something called as, if you got an acoustic shadowing, what's called as dermoid, means it's benign. Dermoid is a cyst where it's a common ones where you can have the ovarian tissue outgrows into different body tissues. That means it can have skin, it can have teeth, it can have lots of parts, all right? But if it is malignant features, or if it's multilocular, like there is too many cysts, if it's more than 10 centimeter, and if it doesn't look like dermoid, and if it's a lot of blood flow, when you do a scan, there's a lot of blood supply to that cyst, it could be a malignant cyst. And particularly if you have got a lot of fluid along with, it could be more suggestive of cancer. So just to, this is just a sort of what do we generally do? Simple cyst, as I see here, if it's less than 5 centimeter, don't worry about it. We'll probably reassure it. It's all okay, nothing to be done. 5 to 7, we may want option, maybe have to rescan or refer to gynecology if it's more than 7 centimeter, as not as a routine appointment, not a 2 week wait appointment. Whereas if it's complex, i.e. different other features, we would do a blood test. If it's CA1 is raised, then you will go to the gynecology. But if it's worrying features, if it's something we are worried about, then we need to do the blood test, as I talked about, CA125, and we need to refer as a 2 week wait cancer referral. It's premenopausal and postmenopausal. Yeah, postmenopausal, as once you've gone through your change, then we would be a bit more concerned about managing the ovarian cyst, that we would probably advise sometimes surgery to remove it, to get a histological diagnosis. This is just about the different ways we can manage. So it's just, in summary, I've covered everything, hopefully, but I'm happy to answer any questions because that may be a bit more useful. Thank you.
Thank you very much, Mr. Calco. If you stop sharing your screen, I'll
Yeah.
put you in the middle, and then we can have some questions.
Yeah. Thank you.
If you just go to the top, have you pressed stop sharing?
Oh, yeah.
That's it. Lovely. Thank you. And then we can bring you into the center. So someone has asked about the link between breast cancer and ovarian cancer. Are those two linked, or is there some kind of is there a link basically?
All right, that's a good question. Most cancers, thankfully, are not genetically linked. But when somebody has got a breast cancer, we would check for a genetic, something called as BRCA gene, and not everybody gets checked. There are criteria in which they get checked. So if you got a BRCA mutation, there is BRCA1, BRCA2. There are two different gene mutations. If you have those gene mutation, then they raise an increased risk of ovarian pathology or cancer. So your oncologist would discuss that with you, but not every breast cancer is related to, or to genetically linked. So now, if you have a breast cancer and you do have advised to have a genetic testing, and the genetic testing shows your BRCA1 mutation is positive, then you'll be referred to the genetist to have a discussion around removal of your ovaries, because they are hormonally driven, and the removal of the ovaries could help in terms of the breast cancer treatment as well, and then obviously can potentially reduce the ovarian cancer risk. Yeah, there is some link, but it is not like until you have, if this is like the Angelina Jolie had, she had breast cancer and she went on to sort of have a mastectomy, and then she also had her ovaries removed. So that was only if you're genetically BRCA gene related. Otherwise, that's not related.
Okay, lovely. Is there anything that people can do to decrease their risk of ovarian cancer?
Yeah, I mean, in general, that's just general, not specifically with ovarian cancer, but in general, obviously, our lifestyle. There are a lot of gynecological cancers, particularly breast cancer and endometrial. I treat endometrial cancer regularly. One of the main things is the weight, our metabolically increased BMI, because if you're a high weight, your body's fat gets converted to estrogen that stimulates the lining. So there is some link with obesity. Obesity is related to 13 cancers, including the breast and the uterine. That's one thing. And then being more active and reduction in alcohol and smoking in general. There is nothing specific for ovarian cancer. But there is some protective effect with somebody being on the oral contraceptive pill. but then we don't advise somebody to go on the pill to get some protection for ovarian cancer. But the most important thing, as I said before, that if you got symptoms, then go and get it checked, because that could be the main thing you can do is to don't ignore some of the symptoms.
Okay. There's another question about ovarian cancer in sort of link with periods and menstrual cycle. Would it kind of affect the menstrual cycle at all?
Yeah, it's not that common, particularly unless you have an estrogen secreting, because there are different types. I didn't cover that bit. There are different types. Just to keep it simple, in terms of ovarian cancer, that is depending on which type of ovary cells are, has growing. Cancer is nothing but the cells overgrow. Depending on which part of the ovary overgrows, it's called different types. Serous type, and there is a granular cell which actually secretes estrogen. That means these are the women who can have some menstrual abnormalities, but in general, not. And as I said to before, thankfully, these are mostly more common in women who have gone through the change. So therefore, if you've gone through the change, you start having bleeding, then obviously that's an abnormal sign and you need to be seeing your doctor anyway. So any bleeding after somebody has gone through the change is abnormal and that needs to be looked into until we make sure it's okay. So not general in a premenopausal woman, postmenopausal woman, when you've gone through the change, certainly, yes, we do say that it can be linked and we need to investigate.
Okay, lovely. Are there any kind of less common symptoms that somebody might, something like someone's mentioned low back pain? I don't know whether that would be a sign.
Yeah, no, back pain is a big causes, isn't it? I mean, you could, there are a lot of other reasons. So usually it's not like the symptoms, it's not in the one of the symptoms which we would say that you need to investigate that. But obviously, if you, particularly bloating, as I said, pelvic pain is a more common symptoms associated with ovarian cancer. Backache, unless it's an advanced cancer, probably not. That's not probably an indicative one. But then if you're doing investigation for backache, then if it's associated with ovarian, you would pick it up on the scan. So generally not a feature of ovarian cancer.
Okay. I think that's it for questions now. So thank you very much for your presentation as well. Thanks again to Mr. Ganguly. But I really appreciate you guys presenting. It was really informative. So yeah, I think that's it, unless you guys have anything else you want to add.
No, thank you. Thank you, Julia, for your time and
Lovely. Okay.
inviting us.
Thank you very
All
much,
right.
guys.
Take care. Bye-bye.
See you. Bye.